Okay, first you expose the patient to mid-thigh. So for this case, upper. So first we do inspection from the front. From the front we can see is there any varus or valgus and any swelling or not. Then we move to the lateral to see any genu recurvatum, means there's the hyperextension. Then we go to the posterior to see any Baker's cyst at the posterior of the knee. Okay, then we assess the gait of the patient, ask the patient to walk. So usually in knee examination there will be antalgic gait. Then we sit the patient at the bedside. Then we inspect the patella. So we ask the patients to extend the knees to see any inverted J sign. Inverted J sign means the patella is unstable. So it will like this. This is normal one. Okay, next. Next, we lie the patient down and we do the inspection again. Now we look for closer inspection to see for any hyperpigmentations, wasting. So wasting, we usually look at the VMO, the medialis of the quadriceps, and here. And we look for any scars, the arthroscopic scars. Okay. Okay. Now we feel the patient's legs. Now we feel for the worm from the proximal to distal. Okay. Okay. Then we're doing now. And meanwhile, we have to look for the inspection of the patella gutter, which is here. You can see a slight depression on the medial, the gutter. This is called the gutter. Okay. Then, if there is the gutter is not visible, that means there's some effusion. So we want to know is the effusion is minimal or a lot. So for minimal, we do fluid shift. Fluid shift first, we concentrate the fluid at the knees. So we put down. Then we push the fluid to the lateral, and we push back on the lateral. Push from the medial, and we push it back on the lateral to see if the bulging. This is called a fluid shift. After we doing a fluid shift, then we do patella tap. Patella tap is for massive effusions. So same like the before. So we concentrate the fluid on the knees. Then we try to tap the patella. If positive, you can feel the bounciness beneath the patella. That's positive patella tap. Means there's a massive effusion. After that, look, feel, move. We move the patients. Oh, sorry. Oh, patella grind. Okay, we got another one, patella grind. So patella grind, we stabilize the patella on both sides. Then we try to move the patella. We push the patella inwards and try to move. If positive, means the patient having pain for patella grinding test. That is indicate for osteoarthritis. Then we move the patients. First, we ask the patients to extend the knee as maximum as they can. So we will put the hand below the knee, extend. Ask the patient to extend. Same with the other side, extend. So in case of some thick flexion deformities, they are unable to extend the knees to 0 degree. And then we do flexion of the knee. We ask the patient to flex the knee as much as possible. Both. So it's usually the knee flexion and extension is 0 to 135 degree. Okay. Done. So now we put the patient's leg in 90 degree of knees, and we also look for now we inspect again. We inspect for posterior sagging to look at the tibial tuberosity. If there is sagging, you can see the depressions of the tibial tuberosity. Special test. Okay, now we're moving on to special tests. So the first one is anterior dorsal test. So if there's any sagging of the tibial tuberosity, we have to make sure we correct back before we do the anterior dorsal test to prevent false positive. So for anterior dorsal test, make sure the knee is at 90 degree. So we sit on the patient legs. We make sure the hamstring of the patient is relaxed, and we put our hand on the tibial, and we try to displace to the front like this. Same goes to the other side. This is anterior dural test. Then now we do posterior dural test. It's the same thing, we just push it backwards like this. After this, we do latchman. Latchman, the knee angle is at 30 degrees. So the easiest way is we put our leg beneath the knee. You put your hand in one in the femur, one in the tibial, and we try to displace the knee upwards like this. If you can see the movement, means there's a positive latchman test. This one is very specific for SCL tear. Okay, after that we do varus and valgus test. So for valgus and valgus test, we have to test it in 0 degree and 30 degree. So we do the 0 degree first. So first you have to lateral rotate the patient legs, and now we do a varus test. So varus, we are checking for the lateral collateral ligament. So we push like this. If the patient have pain, means it's positive. And for valgus test, same, we lateral rotate the patient legs, and we put the stress on the medial collateral ligament. So we just push like that. Okay, done. Then we do it at 30 degrees. So we will let the patient's leg hang at the back side. Same, we do the varus test first and valgus. Okay, yep. Now we are moving on to the McMurray test. So for McMurray, if you want to test for the medial meniscus, we have to lateral rotate the patient legs, and we try to flex and extend the knees at different for multiple times. If there's pain at the medial meniscus, it will be this will have a pain at the medial joint line. Then we do for the lateral meniscus. So we internal rotate the patient legs, and we flex and extend it at different angles. So if positive, there's a pain at the lateral meniscus. That's all.